And now we have none other than Dr. Sanjay Chaudhary. I think he is one of the largest ICL users in India and the most experienced of the entire gamut of surgeons in India. So he'll be talking on vault. How much is safe? All to you, sir.
Thank you, Dr. Sonu. So first, let us say there are two things which are important when you're doing an ICL implantation. One, how do you do the sizing to get the right vault? And second, what if you have not got the right vault? What would you do? So here, I would be talking about situations where the vault has not been right and you have to do something about it. What? Let us see. So this is a normal vault, 500 microns, which is 1 corneal thickness. And we say the vault should be 500 microns plus minus 250. That means 250 to 750 is a normal vault. These days, we say 250 to 1000 is the normal vault, because it is good to have a little more vault than a little less vault. The reason being that the lens becomes thicker with age and the vault decreases, not because the ICL position is changing, but because the lens is getting thicker. So that is why a 1000 vault is now considered a good vault. This is the protocol of safety given by STAR, which says if the vault is less than 100, try to look if there is a central touch. If not, let it be. If it is between 100 and 250, naturally you would not have a central touch. Try to look for a peripheral touch. If yes or no, just keep monitoring. 250 to 750 is just the right vault. Probably now 750 to 100 is also the right vault. And only over 100 are you supposed to be looking whether I am going to be in some kind of a problem or not. So this is a shallow vault. Vault is 212. We did an ASOCT. There was no central or peripheral touch. The ICL itself has a vault of about 80 microns. Because there is a central hole and there is aqueous flowing under the ICL, between the ICL and the crystalline lens, even in a shallow vault. So the crystalline lens is continuously being bathed by fresh aqueous. So the lens is safe. And one really does not need to think of removing the ICL even with a very shallow vault. Just keep observing. As long as the aqueous is coming under the ICL, the aqueous is kind of lifting up the ICL to some extent. And we are just observing, and normally for years together, nothing ever happens. However, here I am showing you a case. If you see on the left side, the ICL is touching the crystalline lens. It's a shallow vault. And to get a better picture, I dilated the pupils to show you the whole anatomy of the ICL to the crystalline lens. It's very shallow here and it's touching at this place. This was a lens which did not have a central hole at that time. If it had a central hole, then there would have been aqueous flowing between the crystalline lens and the ICL, and this kind of a touch should not have been there. But anyway, even after this touch, it took 5 years to get that little cataract there at the periphery. And look at on a slit lamp, this is how it looked in the periphery. Now we were wondering, it was new to us, it was right in the beginning, say 15, 20 years back when we started these lenses, and we really didn't know what to do, and there was not many people to guide us how things would be. So still everybody said that now that there's a cataract, you have to do a cataract surgery, so might as well wait and see what happens. So it took another 5 years for the cataract to come to a little distance in the middle, and that is when we decided that we'll do a cataract surgery. The patient didn't mind. He had enjoyed the best part of his life, 10 years without glasses, had a very high number, and the surgery was uneventful. More concerning is the high vault. Like this here, and if you see like this, there's barely a threadbare gap between the underside of the cornea and the front side of the iris. These situations are a little difficult situations. Now, here see this. The vault is 1456. And still, the angle is about 10 to 15 degrees, 10 degrees. So, as long as the IOP is normal, ASOCT, most of us has ASOCTs now because all of us are doing OCTs for the retina. So, ASOCTs for the anterior segment, pupil size is normal. You don't have to do anything about it. Let it just continue. Just keep monitoring it. When do you really need to do an ICL exchange? You would do an ICL exchange when these problems are happening immediately. One, there's a high vault with angle closure in any one quadrant. ASOCT, you can see there's an angle closure here. The rest of the quadrants are open. So this merits immediately ICL exchange to a lower size. High vault with a large pupil. Now what is so special about a large pupil? When the vault is high, it's pushing the iris forward. It could be enlarging the pupil. The contact between the iris and the ICL is strong. And if the pupil gets enlarged, its contractibility also reduces. And that is when people with large pupils will have a lot of glare even during the day. So, in such cases where the pupil is becoming large, severe post-operative night glares, even at daytime he could be having a lot of glare, it warrants a lens exchange. And you keep monitoring the endothelium. If you think there's a slight endothelial loss, you can monitor the patient for 1 year and then take your call. Now, why I tell you that even if it is a high vault, you should not be rushing into the ICL exchange. The reason is that the vault comes down with time. Now, if you see this, this started with as a vault of 1568. And at 1 month, it was more or less similar. At 8 months, it is 1300. And at 1 year, it's even gone down further. And the vault came down by 390 microns, 400 microns in 1 year. Not bad. So I didn't need to remove this lens at all. The question is, why does the vault come down? There has to be a reason. And the reason is that the ICL is tight. It is supported on the ciliary body. And it's pressing on the ciliary body hard. And the ciliary body is a soft, spongy tissue. So as it keeps pressing hard on the ciliary body, it kind of dents the ciliary body and spreads out. And so the vault keeps coming down to a certain level and then it stops. Now, vault is usually a problem when the white to whites are small. Because, an example here, if the white to white is small, a little higher size is certainly going to raise the vault very high, and a little lower size is going to make the vault come down drastically. So see this, the white to white was 11.1, we did an ICL size 12.6, and look at the vault we got, terrible. And the left eye also, we got a vault of 1376, in the right eye we got a vault of 1400. So, we said, okay, this warrants an urgent exchange. So we took out the lens and replaced it by one size lower, from 12.6 to 12.1, 12.7 to 12.1, and see what happened. The vault in the right eye became perfect and it came down by 666 microns. And what happened to the left eye? Just by reducing one size lower, the vault came down to 1100, it reduced by 1100. See the level of fluctuation. So, it is the high vault which is more worrisome and not the low vault. Thank you so much.
Thanks, Dr. Sanjay Chaudhary, for that wonderful description of the vault. So I think that brings us to the end of this wonderful IC. And without wasting much time, we have the next session, the APO award session. So thank you very much.